Okay, I'll just go for it. Okay, so I'm Russell Langley, and I've got with me Caroline Heisman.
Oh, yeah.
And we're acute oncology specialist nurses. Today we're going to look at the acute oncology service, acute oncology and COVID-19, and really key facts on oncology emergencies and how to refer to us, any useful tools and resources. If I can have the next slide. So the acute oncology service runs 9 to 5, Monday to Friday. We usually aim to review patients within the first 24 hours, but obviously if there's a bigger emergency like a core compression, neutropenic sepsis, we will get there a lot quicker. So definitely during office hours, contact the acute oncology team, and we also like to be notified if the patients that we've been seeing has been discharged. So next slide. We're primarily a nurse-led service. We can get hold of the oncologists. In Eastbourne, we have an oncologist on a Wednesday for about an hour and Friday afternoon. And Conquest is Fridays. Yeah, so mainly Fridays we can get hold of someone.
But by email?
Yeah, certainly we can get hold of them, yeah, by email and by telephone. There are 3 acute oncology specialist nurses working across the site. I'm at Eastbourne. We have David Sharp over at Conquest, and Caroline works cross-site. Some of the numbers you'll see we leave in the notes actually directs to Annie. Annie's our support worker, and she'll man the emails or the referrals and get them out to us as soon as she can. Next slide. So the patients that we like referred to us, anyone having chemotherapy. Oh, there we go. Just clear that from the screen. So anyone having chemotherapy, any systemic anti-cancer treatment really, neutropenic sepsis, radiotherapy side effects, core compression, certainly without getting onto it straight away. Brain lesions, any cancer unknown primary, malignancy unknown origin, and hypercalcemic patients. So that's the key areas that we follow, but we will help signpost to any other areas as well. Next slide. So over to you.
Okay, so acute oncology referrals. Please send us an online referral via the drop-down menu on eSearcher. This enables us to appropriately action your referrals as soon as possible, and please input as much information as possible on the referral form. You can contact us via our mobiles, as we've just said, and the numbers are found on the acute oncology page on the ESHT intranet. Out of hours, you can call the emergency line, which goes through to Pevensey ward, any questions on chemotherapy, and certainly for oncology emergencies, you can phone the registrar at Brighton, and this is any time at the weekend. They're really, really helpful. Next slide, please. So this is how you do the referrals, just going back to basics. So if you select patient documents on the left-hand side of eSearcher, you'll be greeted with this page. Next slide. So on the drop-down menu, just select acute oncology referral form and then press go. Pre-populated form with basic patient information is generated. If you haven't done this, please complete this, as I say, with as much detail as possible, and then save a copy and press send view referrals. Next page. Input the necessary information before browsing and attaching the completed referral document. This will immediately be shared with the acute oncology mailbox. We say it's checked twice a day, but actually we leave our emails open and we look at it probably as much as every hour, and it's probably the quickest way to get in contact with us, because sometimes our phones are in black areas if we're in MRI or in the basement. Next slide, please. This is a useful links page, which is on the acute oncology page if you go on the intranet rather, and it's got some really good links. UCONs and flowcharts and such like. Next slide, please. So acute oncology pathways and COVID-19. So during the pandemic, we've tried to minimise the risk to our cancer patients, and we slightly amended our ways of working. As you know, cancer patients are most vulnerable and at risk of becoming seriously ill due to their reduced immunity from the cancer therapies and their diseases. What we've done is, I mean, clinics were mostly changed from face-to-face to telephone clinics, and treatments were suspended for our palliative patients, as it was decided that the benefit was outweighed by the risks of them contracting COVID. This has inevitably led to an increase of presentations in A&E with progressive disease and complications such as subacute bowel obstruction and end-of-life care. We can always provide guidance over the phone if we can't come to a red area. We can liaise with our oncologists and the CNS for speciality teams. And we always favour an early discharge as long as it's safe. And we try to bring patients into ambulatory care or same-day emergency care. Our patients have all been shielding. I realise they still have to be swabbed, but they're quite normally negative. Next page, please. Which one's this? So I'm just looking at that slide. Management of patients. Okay, I think I've said this really, there's an ongoing 24-hour advice line for patients receiving a SAC. That's the PEMC number. Sepsis patients follow the same A&E pathway with the door to needle time being 1 hour, and put in a side room if possible. If they are suspected of having COVID, they obviously have to go through the red pathway with rapid testing, and hopefully if they're negative then they can get put in a side room. If patients are on immunotherapy and they've therefore started on high dose steroids, say due to immunotherapy related colitis, then please consider PCP prophylaxis of Septrin 480 milligrams Monday, Wednesday, Friday. Next slide, please.
Okay, so we'll look a little bit at neutropenic sepsis. So neutropenic sepsis is a systemic infection of a patient with a decreased neutrophil count. It is a preventable death, and with neutropenic sepsis, or anyone suspected of neutropenic sepsis, we want someone treated within an hour of arriving to actually having the antibiotics, and that's a local protocol, and it's actually national protocol as well. Next slide. So yeah, these patients are at high risk of infection. They may be unable to mount an inflammatory response, and just be aware really, because normal signs of infection may actually be absent. These patients do deteriorate rapidly, and the thing is, we're actually using a lot more aggressive chemotherapy. We're getting a lot better at managing chemo and side effects. The anti-sickness medication has improved quite a lot, but as a result, neutropenic sepsis is becoming a lot more common. So just to be aware of that, really. Next slide. And next slide, please. Can we go to the next slide? Oh, thanks. So neutropenia usually occurs 7 to 14 days after chemotherapy. That's when they're most at risk of developing an infection. We'll class anything under 1 as neutropenic. Certainly anything under 0.5 is very low and critical. Next slide. So these are typical things you'll see with sepsis. Oh, what's happened to my screen? I've lost the slides. What's happened there? Slides.
I'll put it back.
We have got them, but
the slides disappeared.
Mina,
Me and the slides gone.
the slides disappeared. Is this to do what we've? It's not us, is it?
No, it's just gone.
It's not you, it's me. I don't know what happened. Bear with me.
I'll bear with it.
Okay.
We'll leave it to the,
Yeah.
leave it to the professionals. We
Yeah.
probably mess it up. That's good.
Oh, there we go. Yeah.
It.
We are.
Oh, I don't know what slide we're on.
Yeah.
About 10,
we're here.
4 or 5 pages in.
Yeah, we're here.
That, and then the next one. And the next one. Oh yeah, so there we are. Yeah, so I was just looking. I mean, you know all this anyway. Signs of sepsis, pyrexia, cold clammy, hypertension. If you're getting confused, lethargy, that's getting more extreme. So on to the next slide. So diagnosis, blood cultures, following the neutropenic sepsis pathway, sepsis 6 guidelines. Sepsis 6 has made it a little bit, has made our life a little bit more difficult, I think, because when it says chemotherapy, I think it's number 4 that goes down. But really, it's if anyone comes in and they've had chemotherapy and they're a week post and they're unwell, then they need to be treated as potentially neutropenic sepsis. So if you have anyone that you're thinking this is possibly neutropenic sepsis, then they need to be started on antibiotics. So blood cultures, antibiotics, and get that in before within an hour. And we are recording all the data. So anyone that comes in with potential neutropenic sepsis, we're recording the time they come in and the time they get the antibiotics, and all that data is uploaded and shared across the network. So we are watching. Next slide. So patients should present with this. This card was invented to really make it known to the patients that if they leave it at home, they sit at home with a temperature, then it could be fatal. But they should present that to A&E as well, just to make you aware that they're on chemotherapy, and they need to be seen as soon as possible. Next slide. So with the sepsis pathway, there are PGDs in place, as there are some nurses in A&E and MAU that can give antibiotics, the first dose of antibiotics, without a doctor's prescription. Really, the patient's not to be moved from that area until the first dose has been given to prevent any sort of delays. And then when they're admitted, for the antibiotics to be reviewed daily. Definitely call the acute oncology team to a referral, and we'll get down and see that patient as well. Next slide. So here I put a case study, just a typical kind of bit of a grey area, really. So here we've got a 65-year-old female with a diagnosis of metastatic breast cancer, admitted 1 week post chemo, feeling unwell, and on examination didn't show any obvious source of infection. No diarrhea, no pain, no burning, passing urine, no mucositis, no sore throat, chest was clear. Okay, a little bit tachycardic, 98. Aporexial, 36.5. Couldn't really put your finger on anything much. But on further questioning, she says how she's been feeling cold at home, but not really that cold now. I do tend to ask them if they take paracetamol, because sometimes they take paracetamol before they come into A&E, which does mask things. But anyway, in this case, they waited for the blood results. So it wasn't actually 90 minutes from admission until the blood results were reviewed, which showed neutrophils of 0.13 and a CRP of 240. So this patient did have an infection. So by the time that was looked at, prescribed, given, we're looking at about 120 minutes, a couple of hours from admission until the antibiotics were given. So, here we got a delay of an hour, at least an hour afterwards, and didn't really show any signs of infection in terms of pyrexia until about 4 hours afterwards. So really, that's just to show you that kind of grey area. You kind of get where they're not. It's not obviously sepsis like you might see in some other patients. Okay, next slide. Yeah, so when they worked out they're mastering chemotherapy, they invent cancer immunotherapy, just to put a spanner in the works. It's just been really shown some really good effects on patients. But immunotherapy uses our immune system to fight cancer. It works by helping the immune system recognize, target, and attack cancer cells wherever they are in the body. So essentially, it finds the protein unique to the cancer cell it's seeking, attaches to it, identifies it to the immune system, and destroys it. So in difference here, we're noticing that patients will present with problems related to immunotherapy, could be hours, months, or sometimes even years after they've had it. Next slide. Immunotherapy flare response. It's an overstimulation of the immune system caused by cancer immunotherapy drugs, and often results in anything really with an itis. Anything with an itis at the end, we're looking for. When does it occur? As I said before, it's sort of months. Well, it's got hours, months, but actually years is what we're hearing now. Next slide. So they present with symptoms related to stimulation of the immune system, and that can be minor symptoms or major conditions, which are similar to autoimmune disorders. So, as I said before, anything with an itis really, I've been noticing quite commonly pneumonitis, colitis, hepatitis, nephritis. Those first four we probably see more of, but just some more unusual things. Someone that was going blind, like a neuritis, being a myocarditis, arthritis. So it's really with immunotherapy, you're sort of thinking slightly outside the box, really. Next slide. So immunotherapy flare management. So if you see anyone coming in with immunotherapy, then we would say to follow the UKON's guidelines. The UKON guidelines are a step-by-step guide. It's nationally recognised. It's UKONS. It's on the intranet. It's on the internet. It's, yeah, as I say, it's used nationally, but essentially is to stop the immunotherapy treatment and start them on steroids. That's essentially what it is. It'll tell you all about all the different bloods that need to be taken and further investigations. Next slide. So this is a diagram showing all the different itises. Next slide. So it does make it a little bit harder, the fact that a patient might come in saying they're on chemo, because that's all the word they know, even though they're on immunotherapy. But hopefully they'll come in presenting this card, which will make it a bit clearer. Immunotherapy usually ends in the word MAB, so anything with MAB on the end is an immunotherapy. Pembrolizumab, nivolumab, these are the ones we're having a lot of side effects with, but hopefully present with one of those cards. Next slide. So now we're going to have to think, is it neutropenic sepsis, or is it an immune flare reaction? So figuring out actually what are they on? Are they on chemo, or are they on immunotherapy? Next slide. And so you can see the differences here, because with neutropenic sepsis, you're looking at about 7 to 14 days after having chemo. With immunotherapy, it could be hours, could be months, could be years after they have immunotherapy. With neutropenic sepsis, you would treat on suspicion. You'd have bloods, take bloods, observations, looking out for neutropenia. With the immunotherapy, you're looking out for any inflammatory response, looking out for any itises. The treatment with neutropenic sepsis is antibiotics. The treatment with immunotherapy is steroids. And the plan will either be to give antibiotics if it's neutropenic sepsis, or steroids and other investigations if it's immunotherapy. Next slide. Okay.
Okay, this is the Onco Assist app. It's used by a lot of oncology nurses. It's a useful decision support system app, and it can be used, as I say, for acute oncology patients. It's got good, really clear toxicity gradings on it, and it's a free app to download, and it has drug information, so it's a quick reference for your side effects of cancer drugs, and useful formulas that you can use to calculate, such as it's got the Cockcroft on there, things like that. A lot of us use that. Next slide, please. Right, this is there is a link here. If you can, I don't know if I can do it. Perhaps I won't. Anyway, it gives it's a flow chart.
Press on it.
Minnie, I don't know if you can do it. Mina, I think you left click on it. And it's basically the flow chart for patients with suspected spinal cord compression. And there are two pathways we follow. Pathway 2 being symptoms suggestive of spinal mets without any neurological symptoms, and simply we just scan patients within a week for that pathway. And the one that's more, I suppose, important for us is the pathway 1, which is the urgent symptoms. And symptoms suggest with spinal mets and neurological symptoms or signs suggestive of spinal cord compression. So we assess the patient and do a neurological assessment. If we're convinced it could be compression, start them on dexamethasone, 8 milligrams BD plus a PPI, and organise an urgent MRI whole spine within 24 hours. That should be reported within an hour. And as an AO service, we can help with this. We can run around, get these, we know some of the people in MRI, we can get the scans quickly. We can also phone through to the acute oncology reg at Brighton, get advice to look at scans and results, whether or not the patient needs radiotherapy or not. Also, we'd ask you to do a referapatient.org online neurosurgical referral as a matter of course, even if you don't think they're going to need it. They do like one of those, just in case the neurosurgeons want to take the patient over and do surgery. Obviously, if they're metastatic, it's normally just radiotherapy. And then post-radiotherapy, we can advise regarding weaning doses of DEX. So that's that pathway. Next slide, please, Mina. So this is a quick case study. This is a real patient that we had at one of the hospitals. Now, this gentleman, he's 69-year-old retired builder, and he presented in A&E with severe lower back pain, which he'd had for about 9 to 12 months, which I think dated back to an accident in his garden. He'd also got a history of intermittent claudication and hypertension, not much else. He also had intermittent left lateral and anterior thigh pain and some numbness. He had no urinary or bowel symptoms and no history of cancer. And he was taking, at this stage, for pain relief, cocodamol, pregabalin and Oromorph. So he was already on quite a lot of analgesics. So he was discharged on some TCO diazepam and diclofenac and referred to MSK clinic. So this man re-presented about 10 days later in A&E. At this stage, he had severe lumbar pain, numbness, pins and needles, and virtually no strength in both legs when he stood. He had intermittent incontinence of urine. So it just so happened he'd been to his GP the day before with a cough, and his GP had arranged a chest X-ray. And this chest X-ray showed quite a large 6 centimetre mass in his right lung, which was with the appearance of malignancy and quite a few metastatic spread. So at this point, the diagnosis changed to not chronic back pain, but query MSCC. So the MRI was ordered and the patient went home. Next slide, please. So the next day, the MRI showed significant cord compression, extensive metastatic disease, and then the referrer went out to us. So we started him on Dex, BD Dex, PPI, ordered a CT cap, and referred to the doctors referred to the neurosurgeons. We talked to Brighton, and urgent radiotherapy happened and was planned for the next day. So I suppose ideally the patient should have been referred earlier on, the day before when he came in, and we would have advised starting steroids. That would have reduced his pain quite considerably and reduced the swelling and the damage to the spinal cord. Right, so it's food for thought, really. I wonder whether, with hindsight, the ongoing back pain may have influenced the diagnosis, really, that it was just chronic back pain. Right, next page, please. Right, just to talk a little bit about UConn's tool. So it's guidelines for the initial management, as you probably know, of adult patients who have cancer diagnosis and present as an emergency or unplanned admission with a complication of their disease or of the cancer treatment. This can be found on the Acute Oncology intranet page, and it provides extremely extensive instructions for the treatments of acute oncology patients. It's basically our Bible. It's very user friendly. If you don't know, I'm sure you do, and it's very clear and direct. I was just going to have a quick look at, for example, I think on the next slide there's should be a picture of immunotherapy-induced colitis. Go to next slide. So it's a bit hard to see, a bit small, I'm afraid. I won't go through the whole thing because you can read, but it talks. Basically it grades the colitis really specifically from mild grade 1, which is 4 stools per day over their normal baseline, with no abdominal pain, no mucus or blood in the stool, quite specific, to grade 2, 4 to 6 stools a day over the baseline, moderate increase in ostomy output, moderate abdominal pain and cramps and discomfort, mucus in the stool regardless of the number of stools, nocturnal stools, and persistent grade 1s or persistent grade 1 symptoms. And I won't read them all, but it gives you exactly which bloods that they want you to look at, what tests, what actions to take, and also what scans to order and when to refer to gastro if that becomes necessary. So it's really, really helpful, and you know, we use it all the time. As Russell discussed, prompt treatment of immunotherapy-induced colitis, for example, it can be controlled and can be reversed. So, yeah, next page. So really a summary of what we've said. We're really happy to help. We can access advice from the oncology consultants and the nurse specialists, and we can improve the patient's care, we hope, and their pathway, and also follow them up once they're discharged home. So please refer to us by our phones and ideally via eSearcher. Available tools and pathways are on the intranet. Reminder of neutropenic sepsis, door to needle time for an hour. And immunotherapy, refer to the UConn's guidelines and start steroids early. And MSCC, please refer to us early. And on a weekend, please phone Brighton directly. They're always really helpful and willing to help. And you can get MRI spines on a weekend at Eastbourne. There's slots on Saturday and Sunday. Okay, thank you. I hope that was helpful.
Thank you.
Dismiss. Anything? I don't know if anyone wants to say anything. Well, that's sort of references.
Yeah.
Yeah.
On to mute. Okay.
Any questions?
Oh, yeah.
That's fine.
Okay.
Thank you very much, Caroline.
Okay.
Thank you very much, Russell.
Thank you.
Yes.
Thank you.
Yes. F2s, please remain. Jolie Wilkinson from Wellbeing will be joining us So thank you very much, Caroline. Thank you very much, Russell.